Good afternoon. It's a pleasure to be here with you this afternoon and have the opportunity to speak about the next generation of measures that are required for value-based payment. In my talk today, I'll start by just giving some background about the context for the development of the payment reform or value-based payment movement. I'll talk about the early models and what their results have proven to be. And then I'll spend most of my time talking about where the field needs to go in order for the next generation of measures used in value-based payment to really help us accomplish the results that we're trying to achieve. In summary, we often talk about those results as the triple aim. I sometimes talk about them as the dual or twin goals of improving quality and outcomes while reducing cost and cost growth. So to begin, the genesis of the payment reform movement, I think, dates back to our recognition that we have both a cost and a quality and outcomes problem in US healthcare. And our recognition about some of the gaps with respect to quality and outcomes in the US really, I think, came to national attention around 1999 and 2000 with some of the reports that you see on the screen. Importantly, in 99, the Institute of Medicine, now called the National Academy of Medicine, published a very important report called To Err is Human that called our attention to the fact that medical errors were one of the leading causes of death in the US. And this was shocking news at the time, something that really we had not had it in our public awareness, and really became an impetus for the use of quality measures, not just for academic studies, but also for accountability uses in payment, in public reporting of performance for health plans and for providers, and in the creation of tiered or select network models of insurance products. In addition, that was quickly followed by a report called Crossing the Quality Chasm in 2001. And that report really showed not just a gap, but a chasm between the quality of care that we have and what a high performance system might look like. In terms of the cost imperative, perhaps these data are familiar to all of you, but if they're not, they need to be. What these are showing us is that year after year after year, the US not only spends more on healthcare than any other country on the planet, but we actually also have a steeper rate of rise, a faster growth on our spending by more than twofold than any other economically advanced nation. So those two things together, spending more and getting less, add up to a picture that looks something like this. So in this picture, what you can see is the 38 nations that comprise the OECD, the Organization for Economic Cooperation and Development. And you can see that on the x-axis is healthcare spending. On the y-axis is one indicator of health, life expectancy. But the graph looks the same regardless of whether we plot life expectancy, infant mortality, premature death, maternal mortality, chronic illness prevalence. And what we see is the US, a far, far outlier on our spending, all the way to the right, but not getting what we pay for, not getting longer lives for it, or by any of the other metrics that I described, the value that we would want. And so value-based payment, in essence, is looking to drive us up and to the left. And so how does it attempt to do that? I think all of you are probably familiar with this, but in case you're not, fee-for-service payment is the model that's been the prevailing model. Each unit of service gets a fee, and that gets us lots and lots of services, not necessarily ones that deliver results. Value-based payment looks to establish a budget for a population of patients, and in addition to that, to reward performance both on a financial perspective, managing that budget, but also on a quality outcomes and patient experience perspective, rewarding those facets of care. So as you can hear in that, so much in value-based payment relies on measurement, relies on how sound are our measures, and are we measuring the things that matter the most in order to drive results in the direction that we want to go. The answer I would say right now is that while the measures that comprise our measure sets for the most part all include very, very important things, they are largely an artifact of a fee-for-service way of paying for care. And as a result of that, largely oriented toward process measures, measuring each individual thing that we do, not measuring the results that we get. But before we jump to the next generation of measures that we need, a little bit of background about payment reform models in the early days and what those accomplished. I had the great privilege to be one of the developers of the payment model at Blue Cross Blue Shield of Massachusetts called the Alternative Quality Contractor, AQC, that catalyzed the US payment reform movement that is underway now. It was early in the 2000s, 2006 and 2007, that we began to develop this model, 2009 when we launched it. And what I'm showing you on the screen are some of the early results published by a team from Harvard Medical School that tracked what was happening with respect to improving quality and outcomes and reducing cost and cost growth over the years of the AQC being implemented. And the bottom line is it was accomplishing significantly both of those goals of improving quality and outcomes while reducing cost and cost growth. That's what catalyzed a national movement. Not all payment models are created equal, and the Center for Medicare and Medicaid Innovation has put forward quite a number of models. You see here a summary of those models over the past roughly decade, and three different categories of them. Models that ask providers to be accountable for the population across the entire continuum of care. Models that ask providers to be accountable for an episode of care or a bundle, and those that create accountability just for primary care. And what you'll notice here is that there are two different indicators of whether there were savings achieved. One is, were there savings achieved from a gross perspective, that is before shared savings or quality incentive dollars were paid out, did the model save money? And then net savings after the payment of those incentives, did the model save money? And what you notice is that the larger the accountability, the population basis versus the episode basis versus the primary care, really does seem to be associated with the success in achieving both gross and net savings. So we had 3 of 4 population-based models that had net savings, only 1 of 5 episode models, and none of the primary care models with net savings. The quality impacts were relatively modest, particularly when compared with the model that I showed you earlier, the Blue Cross Blue Shield Massachusetts model. In the Q&A part of this session, we can talk about my hypotheses for some of the reasons why we might have seen such a dramatic improvement of quality in the AQC and more subtle improvements in the ACO models that CMMI has tested. But now moving on to this important topic of next generation measures. I described before this notion of today's measures largely being a product of a fee-for-service way of thinking. And that's what's represented here in what we can call little dot measures, right? Measures of each individual thing that happens in the clinical care setting. But what value-based payment is trying to accomplish is not just good care in the care setting, but good results that follow from that care. So we can think of those as the big dots. Ultimately, we wish we could have a single big dot measure, a very parsimonious measure set to ask providers to be accountable for. that with a single big dot measure for each of the pillars of the triple aim. In reality, where I think we will go first are some, maybe we'll call them medium-sized dots, but they are big dots relative to the process measures we have today related to care and health outcomes. So let's talk a little bit about what some of those might look like. I would highlight for you 3 different areas of big dot measures that we need, and 3 different ways that those big dot measures might be used by those who undertake value-based payment contracts in order to help them be more successful. So the 3 areas of big dot measures that I would say we need are, number 1, measures that are sourced from clinical data that give us clinical outcome measures. You can think of the measures we have today, things like hemoglobin A1C control, blood pressure control. Those are what we mean by clinical outcomes. We actually have very few of them. And so in next generation of clinically sourced measures is important. The second category, which I think this audience is quite familiar with, are patient-reported outcome measures. Measures that address how patients are feeling and how they're functioning, and how well the care that we provide is actually improving those dimensions. And then finally, the big dot measures around health equity. How will those measures be used to drive better results from value-based payment? I think these 3 levers are some of the important ways. First is when we have these big dot measures, we can connect them with process measures in ways that will show us evidence around what the best treatments are for patients with a given clinical profile. And we'll talk a little bit more about that with an example in a moment. A second is to develop profiles of providers based on the outcomes they're achieving, so that those who are in value-based contracts can conduct evidence-based referrals. And that I think is important for those in your field, because as hospitals and physician groups are undertaking these models, knowing who are their valued partners in the rehabilitation space will be critical. So even if you as an organization aren't in a value-based payment model, developing the evidence base on your care and the results you're achieving and using those to market yourself to providers who are taking accountability in some of these models, I think is a pretty interesting business strategy. Third area is, as value-based payment pushes us to think outside the 4 walls of the clinical setting, we begin to have to address the social drivers of health that impact outcomes for patients. And so we need solutions that help us to incorporate the information on social drivers into our care processes. So a few words about each of the 3 different types of big dot measures, and then we'll close. Clinically sourced measures. By this, we mean data that come from the clinical record, that come from registries, that come from biometric monitoring devices, all of that coming together to give us information beyond the kinds of indicators we have today around hemoglobin A1C control or blood pressure control. We know that our nation, starting in 2009, invested billions of dollars to get electronic health records implemented. The HITECH Act of 2009 set aside $27 billion in incentives to adopt EHRs. And that worked. We have about 86% of acute hospitals, 83% of practices, a smaller percent, by the way, of rehabilitation facilities using EHRs today. But the use of EHRs to measure quality and report quality is not very far along at all. We've made very little progress. The development of FHIR and bulk FHIR, I think, will be game changers for that. If that's unfamiliar to folks, happy to talk about that a little more in the Q&A. NQF looks to help to participate in public-private partnerships that will enable a measures-driven approach to prioritizing data standards. So what are the most important measures? And what do those imply are the data that we need to be standardized for interoperability and ease of transmission and reporting. So we can talk more about that. Turning to patient-reported outcome measures. I know, as I said earlier, these are familiar to all of you. They're so central to rehabilitative care. But interestingly, in most of healthcare, they have been very scantily adopted into everyday clinical care. Why is that? I mean, this really gets to the heart of what we're trying to do in healthcare to help patients to feel better, function better. So why is it? Well, I would argue there's three critical barriers to the broad adoption of PROMs at scale. One is infrastructure barriers. We don't have easy ways for PROMs to be collected systematically and at a systematic cadence, right? If a particular condition should be measured every 4 weeks, a methodology for triggering that survey, digitally collecting those data without a human being have to hand a clipboard or an iPad across a table to a patient who's in the clinical setting. The usability of the information. Clinicians need to know, what do these scores mean and what can I do about them? And a business case. There has to be a compelling need for the information. I think some of what I'll share in the next couple of slides makes that business case, but you can be the judge. All of you, I think, are very familiar with the use of PROMs for individual patient care. This slide, taken from the work of Dr. Judy Baumhauer at the University of Rochester, shows a compelling example of how we can track with the red line patients' physical functioning and how that is changing over time as we intervene. In this case, an ankle fusion surgery that really helped the patient to regain functioning, as well as other dimensions of health and well-being. Pain in the green line, mental health or depression with the blue line. So PROMs for individual patient care, we understand their importance. PROMs for use in population-based care may be a new concept for all of you. These data come from some work I led at Blue Cross Mass, and essentially what it's showing us is that for patients who had a hip replacement surgery, the baseline functional status is a very strong prognosticator of whether that surgery will help the patient or potentially harm the patient. What we can see here is that a baseline score of 77 gives us almost near certainty that the patient will not be helped and may be harmed by the surgery. They're simply too high functioning for the surgery to be the right solution at this point in time. On the other hand, for patients with a score of 47 or less, the surgery almost always helped that patient. Now, there's a large percentage of patients for whom we need more than that single metric, but for 40% of patients, one number, baseline functional status, could tell us whether surgery was a very good idea or a very bad idea. And the fact that we aren't using this information to decide who gets what procedures is really wasteful, even outrageous. 8% of patients went through a procedure where they were not helped and in many cases harmed. So as we look to provide value, that is low-hanging fruit. Let's start to use that information. I'll close just with a word about health equity measurement. The Institute of Medicine put health equity on the map in 2001 by making it one of the 6 pillars of a high-performing healthcare system. But it's only in the last year or maybe 2, particularly with COVID having highlighted the vulnerabilities in our system, that health equity has really been something that institutions are committing to taking action on. To do that, to take that action, we will need data that we don't have today, data systematically collected on race, on ethnicity, on gender, identity, and sexual orientation, and other aspects of care where we want to drive equity. And we will need new measures that help us evaluate equity and help us know where we are and how we're making progress. So thank you so much for your attention, and I look forward to our discussion in a short while.